Good day, everyone. First, I would like to thank the ICS committee for this opportunity to present our research. My name is Sasha Vereeck. I'm a fourth-year gynecology trainee and PhD student at the University of Antwerp. I performed this research project as a part of my observership at the University of Sydney. These are our disclosures. The aim of our observational study was to determine whether cystocele type varies between vaginally parous and vaginally nulliparous women, in order to gain insights into the etiology of cystocele. Cystocele is a common condition that is much more prevalent in vaginally parous women. However, it also occurs in nullipary. Green et al. Described two distinct types of cystocele classified on the basis of retrovesical angle and the degree of urethral rotation. The figure shows the distinction between cystocele type 2 and type 3 as seen on translabial ultrasound in the mid-sagittal plane, with the left image being at rest and the right image at maximal valsalva. The most obvious difference is the retrovesical angle between internal urethral meatus and trigone, which is wide open in type 2 and intact in type 3. Cystourethrocoele or green type 2 cystocele has previously been considered to be caused by a lateral fascial defect, while green type 3 cystocele was thought to be due to central fascial defect. However, sonographic studies have not provided any support for this thesis. On the contrary, it has been demonstrated that green type 3 cystocele is associated with a avulsion injury of the levator ani muscle and hence more likely to be caused by birth-related trauma. We performed a retrospective analysis of 464 vaginally nulliparous women who presented with pelvic floor symptoms at our two tertiary urogynecology centers between November 2006 and November 2019. Our control group consisted of 872 vaginally parous women who had visited our unit between July 2017 and November 2019. All patients underwent a standardized interview, clinical examination, uroflowmetry, multi-channel urodynamic testing, and 3D, 4D translabial ultrasound. On imaging, a significant cystocele was defined as a bladder descent to 10 mm or more below the symphysis pubis. Volume datasets were retrieved and analyzed offline by the first author, blinded against all clinical data. Statistical analysis was carried out with CES version 9.4. Of 5,266 women seen during the inclusion period, 464 were vaginally nulliparous. 3 datasets were excluded because of missing volumes. Out of 872 vaginally parous women, 1 patient was excluded due to missing volumes. Compared to vaginally parous women, vaginally nulliparous women presented at a younger age and less often with symptoms of pelvic organ prolapse and urinary stress incontinence. Mean bladder descent on ultrasound was significantly different between vaginally parous and nulliparous women, with 8 mm below and 11 mm above symphysis pubis, respectively. Of 461 vaginally nulliparous women, 9.3% had a significant cystocele on ultrasound, with 53.5% being of green type 2 and 46.5% green type 3. Out of 871 vaginally parous women, 48% had a significant cystocele on ultrasound, of whom 34.7% were green type 2 and 65.3% green type 3 cystocele. This significant difference was confirmed after excluding women with previous anterior repair and/or incontinence surgery. In vaginally nulliparous women, a green type 2 cystocele was more prevalent, while green type 3 cystocele was more common in women who had given birth vaginally. On testing for multiple confounders like age, BMI, asthma, smoking, heavy lifting, and familial history of prolapse, or multivariate analysis, the difference in proportions of cystocele green type 2 and 3 in vaginally nulliparous versus parous women remained significant. In conclusion, cystocele type varies between vaginally parous and nulliparous women. Green type 2 cystocele is more common in nullipary, while green type 3 cystocele is associated with vaginal parity. This suggests that type 3 cystocele may be more likely to be due to birth-related trauma to pelvic floor structures. Thank you for listening.